doing, guys? My name's Mike. I'm going to be giving a talk today. My talk is about pleural effusions. My objectives for the talk are twofold. One, I'd like to go into a little bit of physiology of how pleural fluid gets created and some of the ways that pleural effusions happen. And I'd also like to give y'all a good workup for intern year, a good clinical base to what to do when someone comes in with pleural effusion. So y'all are both going to be interns. Chris, I know you're going to psych. Adam, in radiology, you guys are both be there for intern year. So I'll start with the patient. Guy comes in, he's got CHF. It's not very adherent to medication regimens, and he comes in with shortness of breath and cough, subjective fevers for a couple of days. All of these symptoms have been going on for a couple of days, but nothing objectively measured temperature-wise. He's got the history of CHF, and he's also a smoker. On physical exam, he has no crackles in his lungs, but he does have decreased breath sounds on the right side. In addition to that, he's got no lower extremity edema, and if you're only allowed to order two things for this person, Chris, what two things would you want to see?
Let's do a chest X-ray and a CBC.
Excellent. Okay, great choices. The chest X-ray is going to tell us a lot, and the CBC is going to tell us he's got an elevated white count. Chest X-ray comes back, he's got a blurred costa vertebral margin on the right side, but his left side looks pretty clear. He's got some diffuse interstitial infiltrates, possibly some alveolar as well in there. We have a gentleman here, basically he's got a pleural effusion, right? Now, the pleural effusion is on one side. And before I continue, I'd like to talk a little bit about how pleural effusions get made, and to do so, I'd like to talk a little bit about how pleural fluid gets really made. It's actually a mystery for a long time how pleural fluid got made. But the way it works is it's just like any other fluid dynamics issue. You've got the intravascular fluid and you've got the extravascular fluid. And there's two forces counteracting each other with this fluid. What two forces do we have? Are there, Adam?
Hydrostatic pressure and osmotic pressure.
Osmotic pressure, so hydro. And osmotic. And that's true for the capillaries of the chest wall as well as the capillaries of the lung. Now, when you breathe in, what kind of pressure do you have in your lung space or your pleural cavity, Chris?
Negative?
Yes, negative pressure, absolutely. It's sort of a negative pressure gradient. Within the lung space, there's negative pressure, and here the chest wall becomes a little bit less so negative. So actually what happens is that decreases the hydrostatic pressure because there's actually going to be a pulling of fluid from inside the capillaries into the pleural space. And this has even more negative pressure here than this space. So fluids in general are going to just kind of go from here into the pleural space and then re-uptaken by the capillaries of the chest wall. And there's also lymphatic stroma. There's lymph vessels all throughout the lung and throughout the body in general, taking up cellular debris as well as fluids. So these lymphatic stroma exist in the chest wall, and they absorb some of the fluid as well as the cells and whatnot. Of course, there's ways that this becomes increased, and they all have to go back to sort of this type of presentation, or due to increased capillary permeability, or due to increased vessel permeability. So you can sort of put them into two broad categories. Chris, what would you think those two broad categories for evaluating pleural fluid or a pleural effusion would be?
Serous or I'm forgetting. I'm going to need some help.
Yeah, okay.
Transudate versus exudate.
Yeah, transudate versus exudate. Transudate happens when you have an increase in hydrostatic pressure or a decrease in osmotic pressure, and you get kind of a filtrate of fluid. It's basically the same as what the pleural fluid would be like normally. And exudate happens when you have a breakdown of basically an inflammatory response within the vessel, and you got an increase of leakage of all kinds of stuff. You got an increased exudate, cell extrusion, and an increase of proteins as well going out of the cell. And Adam, do you know the name of the criteria involved in evaluating?
I believe that's Light's criteria.
Absolutely. And it's one of the following: concentration of pleural proteins in the pleura being more than half of the serum proteins, the pleural LDH being more than half of the serum LDH, or the pleural LDH being greater than 2/3 the upper limit of normal for serum LDH. So any of those three things would lead you to believe you have an exudate. And now going back to our patient here. In this case, in the case of CHF could be a common cause of And in CHF, you've got a backup of pressure here due to the fact that your left ventricle is not pumping enough. It gets back in the left atrium, and it causes fluid to be forced out due to hydrostatic pressure into this region and be pushed out into that region. So we get a transduate here. Would you think that would be a bilateral pleural effusion or a unilateral pleural effusion?
Bilateral.
Absolutely. So in general, if you find someone with a history of CHF and they come in with a bilateral pleural effusion, you don't have to immediately tab it. You can diurese them. Within 48 hours, you'd expect that to go down. Especially if you see other signs of a heart failure exacerbation. Maybe they have crackles in the lungs or some serious infiltrates. In our patient's case, remember he had a unilateral. So anything unilateral or fever, if you have fever as well, or chest pain as well. Any of those three things warrants a tap, warrants taking a look at the fluid and analyzing it. And so let's say the fluid came back transduate. Do you guys know any other reasons, any other causes of a transduate?
Hepatic.
I'll give you guys a hint here.
Low albumin from hepatic
could
failure.
be another reason why. So liver failure. You can also actually get with liver failure if you've got significant ascites. Sometimes that ascites sort of extrudes into the pleural space as well. But let's say in this case we actually have an exudate, right? Exudate meaning that we have a localized inflammatory reaction. That could fall into a bunch of general broad categories. We could have an infection, certainly. We could have also a malignancy can cause it. Malignancy does it a couple different ways through a localized inflammatory response, and also it blocks lymphatic. It can sort of, if it grows into this space, it can block the lymphatics. What else would we want to get? What other tests would you want to run on that pleural fluid if we ended up with an exudate?
Cells.
Cell count, absolutely. Cell count. So you want a cell count in differential. If you got a lot of lymphocytes, you really want to think about doing a TB test. Other things that you could do is, you'd want to get a glucose level that has numerous different evaluative properties. And also a cytolytic analysis, especially with this guy because he's a smoker, a long-time smoker with a chronic cough. Cytologic analysis, and also if you end up with something that's looks kind of purulent, cultures are a really good idea as well. If everything's kind of coming back negative, one thing that causes an exudate, and that also can cause a transduate as well, that can also cause shortness of breath. That's kind of the rule out diagnosis. There's tests to do it. To find out would be a PE. So if you end up kind of coming back negative, everything else, you've got an exudate, but no other real cause for it, a PE would be something to consider. Any questions?